Hello, here we are for part 2, central nervous system. So let's get right at it. I got it. All right, so we'll get to strokes, which are a major killer. And almost always atherosclerosis is involved with strokes. So generally look at the health of your arteries, and that will tell you your stroke risk. So it's caused by a sudden neurological deficit caused by either a vascular occlusion, meaning a thrombus or a clot forms, or an embolus forms in your leg, in your heart, it's given off, goes up the carotid, gets stuck in one of these tributaries in your brain, and it blocks off blood flow to part of your brain. That's the most common type of stroke. There's also a hemorrhagic stroke where the blood vessel bursts and it bleeds into the brain, also starving that brain of oxygen and fresh blood beyond that burst. And so they both cause a stroke, but they are two different paths. Your book doesn't talk about TIAs, but transient ischemic attacks, mini strokes. You can have those as well, and it's just kind of a warning sign, like you have angina. It's a warning sign of your heart attack. So most strokes are caused by emboli, a clot, or it could be a piece of fat. It could be an air embolus. Something is going to come. It's going to block off that that artery. And if that artery already has thickening in it, it's more likely to be blocked off, isn't it? But fast, exactly. So if you see someone and they have face drooping and their speech is incorrect, and one side especially have arm weakness, etc., and time is so important. You really got to get those, you see those clot busting drugs in there, like within an hour, hour and a half of symptoms in order, because that brain tissue beyond there quickly is going to die without a good blood supply. Yes, so again, I mentioned time because you may have that blockage of the vessel, and the first second you may not notice anything, but pretty soon those brain cells are going to be starved for fresh oxygen and glucose, and so you're going to lose function, and then that part will become necrotic and soft, and then it's going to be die. It's just going to die off, and so you can see this amazing section of a brain with most of one hemisphere has been necrotic. Yeah, a big middle cerebral artery. It could be the right half, depending on if we're looking at it this way, of the brain. Yeah, from a stroke. Yeah, so as I mentioned, it could be any artery blockage or hemorrhage can cause a stroke. There are parts of your brain where if you have a stroke there, you don't even maybe notice it. There's parts, that are not such a big issue. If it's a big artery like your middle cerebral, that whole side of your brain, the motor, you're going to have you're going to know effects right away. If a stroke happens in your brain stem, it's could cause stop of breathing, heart rate, and so that's very quickly a cause of death. And whatever side, this gentleman's right side is drooping, so you know that it's his left middle cerebral artery probably blocked off. Yeah, and if you have a major stroke, yours most likely going to be fatal. The smaller the stroke, smaller artery involved, the smaller the clots, the better your prognosis. And if you're talking about maybe in the vertebral arteries or maybe ones that affect the brain stem, it's going to cause stop your breathing. So not good. The rare cases where you have a hemorrhagic stroke are really bad because you have a bleeding into the brain. And not only does that brain tissue going to die, you're going to have intracranial pressure building up too as the blood leaks out and pushes the normal parts of the brain against the opposite wall, right? So high ICP, your MRI or CT will show the brain just being pushed in the other direction. And you'll often see quite common people around that circle of Willis or cerebral arterial circle, they'll have an aneurysm where the artery will have these balloons, these Berry aneurysms. Don't see it there, but you're going to have these little bubbles, and you may have one and you live just fine, but they can burst. And so that's a cause of a stroke often right there. And they can look at, if they do a lumbar puncture in the cerebrospinal fluid, in this type will often be blood in it. That says, oh, okay, we're bleeding into the subarachnoid space now. Okay, different than a normal stroke, which would be an embolus, simply blocks blood flow. You have a normal CSF in terms of blood. So with stroke, even the people that survive a stroke, they get there quickly, a large percentage will have some kind of issue carry on through their lives. So on average, about a third of people will die from a stroke. Remember, time is of the essence, but even with time, it just depends how major a stroke it is. And then a third will survive it, but they have neurological deficit. Depression is very common afterwards, partial paralysis, all kinds of things can happen as a result of a stroke. And then about a third will recover almost unscathed. So that's the prognosis for a stroke. Remember, this is the third biggest killer. Yes. So how big a stroke, how much of the brain is involved, and then really how quickly and what good care you got right after. If you live close enough to a major hospital, even a minor hospital, get in there and remember, mostly it's a thrombus. They'll give you drugs to break up that clot. And they can even go in after the clot and pull it out with instruments if they need to. You know. So, like I said, when you come to hospital with stroke, you're pushed ahead of the other people. You're immediately, if they can put this plasminogen activators, don't worry about it. They're just clot busting drugs. Push those in you. They will hopefully break up the clot. Now, if it's a fat embolism, it won't work on that, right? So they need to know what kind of thrombus it is, but if it's the typical blood clot thrombus, it's embolus that's a blood clot that just traveled, they can break that apart, blood flow returns. And man, if they can do that before an hour and a half at the beginning, those neurons will not have permanent damage. If it's 3 hours later, you've done a lot of damage and they may restore the blood flow, but it's been too late. So that's that T in stroke is the time. It's just important. You notice someone's symptoms, drooping, one arm weakness, slurred speech, just go to the hospital. A wild picture there of a brain with a huge divot in it. But what happens is that you have death of the whole section that was fed by that artery. And here you can have kind of a fluid-filled cyst. So normally the astrocytes just proliferate and make a scar tissue out of astrocytes. So a scar on your skin will be collagen fibers, etc. In your brain, it will be astrocytes, just kind of glial scar that just fill in the space. All right, so strokes. You guys got it. You know the two main types. You know how you can tell you have one, and you know what you can do about it. All right, so concussions don't leave any permanent structural damage. Now, all of you need to follow high school sports or professional sports know that every time you get a concussion, they have a formula. They look and they say, you know, if you have consistent concussions, it's dangerous and they don't want you to play. Right? Yeah, so, but generally concussions are a blow to the head, momentarily loss of consciousness. But then you get up and you may have headaches and nausea for days, but then apparently the definition is there's no structural damage. So if they look, nothing. But these things are cumulative. And so multiple concussions, a lot of evidence showing that it causes brain damage. And even though your brain sits in this watery fluid as a cushion, you hit your head hard enough, it's gonna hit. It's it's going to hit the front side, or if you're hit, it's going to hit the opposite side too. So the brain is being hit like that. Now, if your brain is hit hard enough that it causes a bruise, it's a contusion. So a contusion would be a hematoma, blood will come out. And that you're at a risk for increased intracranial pressure if you have a hematoma, a bleed. So a bruise on the brain is a contusion is a step above a concussion where you have actual hemorrhaging. All right, then a couple biggies, the epidural hematoma and a subdural hematoma. You guys have heard of these. So these are bleeds, and the epidural is going to be bleeding above the dura, between the dura and the skull, and it's going to push, pressure on the brain. Now it's usually arterial blood. There's arteries up there, and it's going to bleed pretty rapidly, fill up, and get bigger and bigger. This epidural hematoma, and because arteries have more pressure, they're going to bleed faster than a vein. So if you have an epidural hematoma or a subdural, often what you have is, let's say you get an accident and you hit your head and you get a concussion and you consciousness and you feel better, you feel fine. But you want to watch that patient because that bleed, the epidural will be faster than a subdural because that's the veins, less blood comes out. But then all of a sudden, hours later, they can fall into a coma. That's why you want to watch people with a head injury, even if they say they feel fine, because the bleed is slow enough that the blood accumulates and eventually that pressure is rising, but it can take a while before it's high enough intracranial pressure. So always you want to do a scan, take a look to see if they have an epidural or a subdural hematoma. So epidural between the dura and the skull, subdural will be below the dura. So it's pushing, there's not normally a space between the dura and arachnoid, but if there's bleeding, a space forms and it fills with blood. Usually venous blood as opposed to arterial blood. And great illustration. You can see it on a scan. You can see the fluid forming, and look at it pushing the brain and increasing that pressure. Yeah, and so here you can drill some burr holes, I call, right through the skull, and then release that pressure. Yeah, so penetrating injuries to the brain. I mean, first thing you think about are bullets. And if you're shot in the head, you could survive. Yeah, the velocity of the bullet, it's a square of it, so it's a huge variable. So a high velocity bullet does proportionally much more damage than a 22 or something like that, a slower bullet. So you can survive a bullet to the brain, but not a high-powered rifle shot to the brain, of course. So what you're going to have is usually the bone is going to splinter in there. I mean, you're entering infection, let alone just the damage. And the entrance wound may be small, but the exit wound, if it goes through, is going to be, the bullet expands as it goes through your head. So, yeah. But besides bullets, you can have ice picks and industrial accidents. Lots of things can penetrate your skull, and they worry about the actual damage. They worry about the infection because you've broken the skin, and yeah, it's a major issue. A spinal cord too. You know about paralysis. If you injure your spinal cord, definitely. Sometimes it could just be bruised, and it might appear normal, but then it's swelling, meaning that maybe your vertebrae like subluxed and they came back, and it may look intact, but you've damaged the spinal cord in that case, or it could be an obvious severing, or the more normal cases, a bone or a disc can come in and push in that spinal cord as well. So yeah, surgical emergency if you have any kind of spinal cord injury, you put them in the brace immediately because any further movement could do more damage. And they give you a lot of drugs with a spinal cord injury to prevent that inflammation and swelling. To just critical time after spinal cord injury is right after it, in the hours and days after it, to see what happens. And so if we can, you try to get in there and prevent as much damage as possible and hope that it just heals. All right. We talked about Guillain-Barré syndrome and it causing peripheral neuropathy. MS, multiple sclerosis. pretty fairly common disease. I don't know I'll give you the stats on how many people have in the US, but this is an autoimmune disease where you break down the myelin sheath in your brain and spinal cord. So as opposed to your peripheral nerves. And so sclerosis, a sclera is, sclera, oh, the whites are right. It means a tough, it's a kind of a scar, multiple scars or toughness. That happens when you break down the myelin and you have kind of the scar tissue that forms instead. And that axon that was myelinated works less and less and less as it loses that insulating sheath. So it's degenerative. There's no cure. There's some therapies that will help alleviate the symptoms, but it's an autoimmune disease where your body's attacking the myelin. Normally the symptoms, usually get this, it's a little more in women than men get multiple sclerosis, and I believe 20s, 30s, as you get on, you usually get it. Vision, the often attacks the optic nerve, and difficulty walking and tingling. You can look at all these things, emotional changes, headache, muscle spasms, fatigue, definitely. Look at the symptoms that come up most often with this. It's often hard to diagnose. You have these kind of multifocal, many places neurological defects, and so they go in and they often exclude, a lot of things before coming up with an MS diagnosis. The diagnosis can be depressing because there's no cure. It's an autoimmune disease that they can just manage the symptoms. Let's see. Yeah, as you can see, you can live for decades with this. Usually, eventually, you get more and more demyelination, weaker and weaker, and affects the respiratory muscles, and that's the cause of death. So what causes this autoimmune disease? Well, you guys know there's a lot of mystery out there. It probably, there's some genetic component, and then we believe there's people that are genetically susceptible, and then we think there's some kind of environmental trigger that makes these antibodies that are probably made against some infectious disease, and then they're similar enough to the myelin coating that they attack the myelin. You don't want them to, because you want them to attack the bad guys or attack the myelin. So that's the idea. The epidemiology is fascinating in that there's a north to south gradient. It's more common in Canada, Minnesota, than it is in the South, and as you go towards the equator. What is going on, right? A lot of most infectious diseases show an opposite distribution, where you have more infectious diseases in the equator and they get less as you go towards the poles. There's less diversity of organisms, life is tougher, So interesting that that Canada, northern United States, northern Europe, what is going on? And so it's got to be some environmental thing that we just haven't pinpointed yet. And there's a genetic component too, because we know there's a genetic component. Yep. So like I said, the diagnosis can be tough, but if they can, you can see some of these demyelination defects. And then if you do proper staining, they can see that this region, the myelin has been destroyed. If you get a special stain for myelin, so they can see they see some lesions, they see some demyelination areas in the spinal cord of the brain. Yeah. And they can look for this immunoglobulin as well. All right, we're getting weird now. I call these prion diseases, but Creutzfeldt-Jakob Disease is a prion disease that affects humans. And oh my God, we talk about disease. Well, neoplasms are one thing. Infectious disease, we talk about bacteria, and then viruses, which are already weird because are they alive? They have DNA, RNA, but they need cells to divide in. Bacteria can divide on their own. This one is a protein. So we're talking about a disease caused not by a living organism. It's a protein, a normal protein that when it gets in your brain, it starts converting your normal proteins, kind of like a domino effect, and it causes your brain to become spongy, and it's deadly. Talk about scary. And they even found brain tissue that's been preserved in formaldehyde that years later they can take it out, put that little bit of that brain tissue in an animal's tissue, it dies. because these prions, these abnormal proteins will start converting it. All right, talk about scary. Well, luckily, you can't just catch this by, oh no, I caught, this abnormal protein. It's got to really get in there. We see it, I mean, this is a huge scare, the mad cow disease. You can see bovine spongiform encephalopathy, right? So it makes your brain, pathology of your brain, making it spongy. And so super scary, but super rare, all right? You need to this is the cows are being fed, I believe, I don't want to talk right now, I haven't researched this, but look at, they were fed sheep meal, or they were fed animal matter of some sort that transmitted to the cows. And so they killed all these cows in England. It was a big deal, but it infected very few people. But like I said, it's so scary that people really reacted to that. So you're going to die soon after getting this. You do a brain biopsy and you say your brain has these abnormal proteins. So yes, let's take a look here. So the abnormal protein gets into your brain and it just starts replicating and turns your brain spongy. So you're going to lose memory, lose the ability to do any of the brain function before you perish. Also, it's been found some prion diseases in Papua New Guinea. There's cannibalism. This is a long time ago, but that you had a disease where it was transmitted by eating human brains. And then you don't want to eat monkey brains either, generally. Not that you probably were going to for tonight dinner, but another way it's to get this prion. Or you'll see it rarely in organ transplants, because with an autoclave that kills, maybe kills all the bacteria and viruses, it's such high pressure heat. So your instruments are autoclaved. The prion, the protein, might not be destroyed. And so it's an idea of introducing it that way. So, okay, so these are prion diseases that sound super scary, but they're very, very rare, but cool and interesting. Yeah, so you're not going to catch it from somebody. Yeah, and we don't know what to do about it. All right, so we'll move to dementia. So this is a loss of cognitive function once you're an adult, dementia. Talk about it being intellectual impairment as a child, but so dementia is loss of cognitive functions, memory, the ability to higher thoughts. So senile dementia is a very broad term as you get older, and some people, as you get older, your brain shrinks. Your gray matter, your white matter, there's less of it as you get older. But some elderly have just a sharp memory, going back 100 years, and they can. So it's not necessarily true that as you get older, you need to lose your memory. It happens often because of this kind of shrinkage of the brain, but it's not necessarily going hand in hand. You get old, you need to get dementia. But yes, and besides, loss of memory, easily irritable, and, lose short-term memory, is dementia. Yeah, and so how much you're losing, particularly the frontal lobe, is the piece at issue here. 1 in 3 seniors die with Alzheimer's or dementia. So you can see a third of, dying of something. That shows you how common it is to have dementia as you get older. And a form of it is Alzheimer's disease. And I can't even think about it. My mom had Alzheimer's disease, and tough, of course, when I think she always still recognized me and would smile, but to lose the ability to, at first, just to not remember things, keep asking, where are we going, and then not being able to speak, and then having to be fed. And so it's, of course, very draining on the person and also on the family and the people around them. And it's, yes, like I say, it's very, I have personal experience with that for sure. But Alzheimer's is a type of dementia. And so actually the only way to really to say for sure it's Alzheimer's is with a brain biopsy. So you have in the brain, you have these changes that happen. You have these plaques, these tangles. So the neurons, we think these things build up and they prevent the connections. And the brain regresses. It gets smaller and smaller. So an Alzheimer's brain has shrunk quite a bit. See the spaces, there's more space in there. And this amyloid builds up as well. There's hundreds of drugs that are being looked at as Alzheimer's treatments. There's all these ideas, because is it start with an infection, or what is causing it? Is it closely related to cholesterol and vascular? I've just been following all these ideas. So there's a lot of research going on, and your guys' lifetime will know much more about it, and hopefully come up with a way to slow it or cure it. So there is no treatment. If you have Alzheimer's, there's a few drugs that will help with some symptoms, but nothing. You can't, I have Alzheimer's, okay, give me an antibiotic. No, that doesn't work. So you just have a progressive loss of mental faculties until eventually you can't even eat or swallow, and then death can follow. But this can take years and years and years. So the toll, not only emotional toll, the financial toll, and the toll on the caregiver, the spouse or the family is incredible, monetarily and emotionally. And so you can see in the future, Alzheimer's, if you look ahead, these are older age groups, and there's an early onset that usually comes out in your 70s, 80s. There's early onset in your 40s and stuff. And there's a genetic component as well, and they have a couple genes that are possibly linked to it, but there's no gene says you're going to get it. But in the future, we need to really prepare for a huge population as we live longer. More people have Alzheimer's, and I hope that our research pushes forward and we understands what causes it, be able to screen for it, and be able to prevent it. But it's been known, early 1900s, I believe it was German Alzheimer, discovered this type of dementia, and so yeah. Parkinson's is another disease that's the elderly, really, and we know it's you have this substantia nigrum, this basal ganglia in your brain. It's usually darker, and we know that that's where the Parkinson's, the issue is. Those neurons die; they don't make enough dopamine, and you end up with this Parkinson's. Usually isn't elderly, but Michael J. Fox and Muhammad Ali both had it, where you end up having these symptoms. I guess I'll show you in the next slide the symptoms. And you think to yourself, well, why can't you just give dopamine? It's not making it. Well, you can. You can give this dopamine precursor, and it can help some people. But even giving it, your brain reacts by making less of it. The more exogenous, the more you give. And so we see this with many drugs. It's like addiction, where you start smoking, you have nicotine, and your body changes the number of receptors. So it takes more cigarettes to have the same effect. And if you remove it, you don't feel good because your body stops making the dopamine. So yeah, your brain reacts, and then with the amount of it produces itself and the receptors on the cells. So addiction changes your brain. Yeah. So this is your typical Parkinson's. I think you've all seen people with Parkinson's, kind of a trembling and unsteady gaits, astute posture. And like I say, there are some drugs like L-DOPA that can help against these symptoms. There's some surgeries they're looking at. Maybe use stem cell research to try to get those neurons back. But yeah, these are the main symptoms of Parkinson's. And yeah, you'll see many elderly have some signs of Parkinson's, and those of Parkinson's, about half of them have some dementia too. So as you get older, senile dementia, possibly Alzheimer's, and Parkinson's, rigidity, a shaking kind of motion. All right, let's shift gears. Hydrocephalus means water head, water brain. And this is when I've already talked about this, but you could produce too much cerebrospinal fluid. Either you produce too much, or you don't absorb enough, or there's some blockage somewhere where the pressure builds up with this fluid. And when it happens as a child, your skull bones aren't fused, and hydrocephalus will cause a swelling of the head. As an adult, they can't move, so you're just going to have pressure and coma and death if nothing is done about it. Yeah, most commonly in the cerebral aqueduct in adults, if that gets blocked, it's a narrow channel, then it's going to build up here. You can see in an MRI, the ventricles will expand, pushing on the brain matter. And if there's constant pressure, that brain matter dies. And so this is a progressive thing. Yeah, I'm looking at the ventricles, and I can see enlarged ventricles. So normally tumor or some kind of blockage, so cerebrospinal fluid has to be able to flow from those lateral ventricles through little holes into the third ventricle, down the aqueduct to the fourth ventricle. Any blockage there is going to cause a backup of the fluid. And then all of this cerebrospinal fluid gets absorbed in those arachnoid granulations up in your the dural sinuses. And if those have an issue, you got meningeal scarring, then you're not absorbing enough of that fluid back into the bloodstream, and your pressure is going to increase. And so you don't see this very often, full-blown hydrocephalus in a child with modern healthcare. Your physician's going to notice this, all right? And I had a student in my A&P class, and she said, oh, yeah, I had hydrocephalus, and I have a tube running down from my head into my abdomen. And so there's a little, there's just a little pressure gauge. And so if you have too much pressure, this tube, the fluid will press against the valve and release that excess fluid into your abdominal cavity, just gets absorbed. Yeah, pretty smart, pretty low tech, it seems to me. But then they'll put this shunt in there if you have hydrocephalus. And apparently it's not that rare, because I know somebody. But yeah, untreated, look at those ventricles ballooning out, crushing the normal brain. All right, epilepsy. Maybe some of you know epileptic, or you are epileptic, but this is getting recurrent seizures. And the seizure, and I can't get into all the different kinds, tonic, all the things like that, clonic, all these kinds of seizures. The brain pretty much has like an electrical storm where it's, you'll often, person with a seizure, you want to make sure they don't have problems with their tongue. They just to make sure, usually it comes and it goes, and there's medications. Sometimes there's parts of your brain that are, there's damage and seizures originate. So there's many kinds of seizures, but epilepsy is having these seizures. They can have them after an insult to your head, a surgery or an infection or trauma, and you can have seizures following that. High fevers or electrolyte imbalances. You know that preeclampsia, the definition of getting eclampsia is if you have seizures. And so with pregnancy, you can have that. And people with seizures, you can see more likely to drown, often have depression, anxiety, especially if you have epilepsy, the embarrassment of having epileptic seizure and not knowing, when it's going to come on. So you can see how that would feed into depression and anxiety. Yeah. But they can do some things. I mean, they have various epileptic medication. They can look at doing some other surgery type interventions too. All right. So lastly, neoplasms. Talk about muscle, not often you have neoplasms. Bones, you can have that rhabdosarcoma occasionally. We talked about skin being very obviously having a lot of neoplasms, epithelial tissue like in your colon, right, and liver, these places. But what about the brain? Now, obviously brain tumors are a cause of concern, right? Because they're difficult to operate on, and any taking up space in the brain, that every square millimeter of your brain, not every square, there's some wasted space, but there's some really important areas in your brain, right? Your hypothalamus and frontal lobe where a tumor there, and your liver may just take up some space, take up some capability to make proteins, but in your brain, it's taking up where you think about where you have lunch, things like that. So, yeah. And so slow growing tumor in the brain is more of concern than a slow growing tumor in your colon or your liver, because there's just so much critical functions up there. Another problem is it can be in inoperable locations. You got at the base of your brain, you'd have to go all the way through your brain to get to it, you know? And so there's areas with a benign tumor that, God, we'd love to remove it, but it's not worth, you could go blind, you could lose your ability to speak just to get to it, right? So what are signs and symptoms? I mean, things like obviously headaches, seizures, personality disorders, drowsiness, nausea, memory problems, sleep problems, vision problems, all depending on where the tumor is, would be symptoms of this. And because there's a tumor growing, you could have intracranial pressure could increase. Yep. And so treatments, you want it to be in an operable location, somewhere they can get to it without going through a lot of brain tissue, right? So if it's benign, slow growing, if they can get to it, the best thing is surgery to remove it. Now, if it's malignant, if it's growing rapidly, the surgeon will like to get a sample of it to do a biopsy to see what exactly it is. And then, you know, radiation and chemo are the recommended things to try to stop it. Most common is just your astrocytes. They're the most common glial cell, and so they start proliferating, have a neoplasm of them. That's that's the slower growing one. A glioblastoma is other glial cells. That's the more rapidly growing one. You can see death within a year or two. The other big type, besides those ones from the glial cells, is a meningioma, and that's in the meninges. And so often it's benign and in the dura. And the good thing about it is that the meninges are on the outside of your brain. So especially if it's right here in the midline, they can take out a piece of skull and get to it and remove all of it, right? So that's good. If it's on the meninges in the base of the brain in some other places, and your meninges dive deep in all these places, then it's more difficult to remove. But luckily, you know, if it's confined to this benign growth on your meninge in an operable location, removable, and you're not actually damaging much brain. I'm saying any brain really, but if the neoplasm may grow and push into the brain and cause damage, but if it's removable, you can just get it. Yeah, but like I say, a meningioma at the base of the brain, the prognosis is worse. It's hard to get to, and it will continue to grow. And yeah, I mean, imagine one here in your brainstem. Hard to get to. Just getting in there could cause damage to your brainstem, causing death. So, all right. You can also get an adenoma. Remember, it's a neoplasm of a gland cell in your pituitary. Pituitary tumors. You'll see that often causes giganticism, and then acromegaly is too much growth hormone as an adult, and so because you're just producing all those hormones. So you'll definitely have endocrine issues if you have a pituitary tumor. It's just making all kinds of hormones, right? It's a hard one to get to because it's at the base of the brain as well. You can see they'll often go through the nose to get to it, past the sphenoid sinus. Yeah. And yeah, one's in the cerebellum. These commonly in kids, younger people. These tumors will be in the cerebellum. As an adult, you see more cerebrum tumors. Just some generalities. Metastases. So a lot of again, bone cancer, liver cancer, colon cancer can spread to the brain. So metastatic brain cancer. If it travels and it's just in one spot, the tumor they can cut it out. You're good, right? But if it's metastasized in many places, then that's an issue. And the spinal cord does get tumors. usually the glial cells, the oligodendrocytes, and you're going to have a tumor. All right, so brain cancer. Talked about two main types, right? Got the astrocytes or the glioblastoma up there, and meningioblastomas. All right, so organ failure of your brain, death as a result, right? Okay, so if the whole brain fails, but you can have focal issues, and you can have, if it happens to be like in Broca's area or speech area, you could have aphasia, you can't understand or speak words. If it happens to the occipital region, you could have blindness or on the optic nerve blindness. So the deficits depend on where the issue is. And again, if it's overall, you could be in a vegetative state, coma. There's all kinds of consciousness is our ability to see ourselves in our mind's eye, to recognize self and to be aware, to be unconscious. Eventually, coma, you lack even stimulus, does nothing. So there's different definitions here of vegetative state and coma, etc. But yeah, if brain death, you know, having the inability to have any brain activity, are you really alive? Think about it. Even if your heart is pumping, your kidneys are working, are you alive? I mean, without your brain? I mean, what are you without your brain? You're an organism. You're a functioning piece of meat, you know, does all these things. But if you can't think about it, if you have no memory, if you have no nothing, that's what really makes us human, is what's in our head. Again, getting a little philosophical. And how you all define death is, it varies among cultures and even legally among states and such. But brain death, if you take ECG, usually taking 2 ECGs 24 hours apart without any electrical activity, that's considered death. Brain death, which means you can take off support and stop breathing or stop eating and stop heart beating, and because there's no coming back. Barbiturates, you can cause this the same effect. So you want also to be sure to take a blood sample. Okay, they're not trying to kill this guy, but give them barbiturates so they can be brain dead. So anyway, that, look at body temperature things. There's other clues involved with brain death, but normally we define death as brain death, not your heart stopping. I mean, your heart stopping will stop your brain, but your brain stopping will not stop your heart necessarily. See, if you still have just your brain stem functioning, you will continue to breathe and do blood pressure, etc., but you won't have any higher thought. You won't be able to speak, you won't be able to think, you won't be able to hear anything. And so you'd be in a vegetative state or a coma. And people in comas do come back. If you haven't had damage to the brain, there's that possibility at some point. But, and I'm not a neurologist, so I'm not going to go any further on that. But all right, hope you enjoyed central nervous system. Some big issues. Obviously, we talk about heart failure, brain failure. These are some critical organ systems that need to be running. All right.